Welcome to the Deep Dive.
Glad to be here.
We are tackling a really fascinating challenge today, one that gets right to the core of, well, what makes us human?
Yeah, it's a big one.
We are staring down this absolute mountain of neurological data, disease profiles, charts, complex pathologies.
It's an intimidating stack of
It
notes.
really is. We are talking about the human nervous system, this intricate web of, 86 billion neurons?
Give or take, yeah.
Firing electrical impulses at hundreds of miles per hour, regulating literally everything from your ability to take a breath to your memory of your first childhood pet.
Right. And it works seamlessly until it doesn't.
Exactly. So what happens when that system misfires? Today, our mission is to untangle this massive alphabet soup of neurological disorders.
Yeah, ALS, GBS, MS.
All of them. Parkinson's, Alzheimer's, acute crises like seizures and strokes. We are going to figure out exactly how these diseases operate, what they target, and why they manifest the way they do in the body.
It's a massive landscape to cover. When you first look at neurodiseases, it can easily feel like a blur of overlapping symptoms.
Just a list of weakness, tremors, memory loss.
Right. But there is a profound biological logic to all of it. To actually understand what is happening, we have to look past those surface-level symptoms and examine the exact anatomical target.
And for you listening, whether you are prepping for an intense medical exam or catching up for a clinical rotation, or maybe you're just insanely curious about how the human body works, this deep dive is custom tailored to shortcut that overwhelm.
We want to bypass the rote memorization.
We're going to get into the actual physics and biology of these conditions.
And to do that effectively, we need a framework.
A blueprint.
Exactly. We are going to divide every single one of the disorders we discussed today into 3 distinct buckets, based entirely on their core target within the human body.
So let's lay out that blueprint. Bucket number 1 is the pure mind attackers. These are disorders that primarily target cognition, memory, mental status, level of consciousness. The body's machinery might be perfectly fine, but the mind is under siege.
The hardware works, but the software is glitching.
Perfect way to put it. Then bucket number 2, the pure body attackers. These cause physical decline and motor function failure, but they leave the mind completely intact,
Cognitively pristine.
but trapped in a feeling physical vessel.
Yeah.
And finally, bucket number 3 is the mixed bag. Disorders that blur the lines, attacking physical abilities right alongside cognition or language.
Categorizing them this way really simplifies the complexity.
But before we start sorting diseases into these buckets, we have to understand how we even detect the damage in the first place, right?
We need our assessment toolkit.
Let's unpack that. The assessment of a neuro patient basically relies on 3 main tools: motor, sensory, and reflexes.
Starting with motor function, it isn't just about asking someone to squeeze your fingers.
Right, it's not just a strength test.
We are looking closely at balance, coordination, tremors, and crucially, muscle tone.
And tone is broken down into spasticity, rigidity, and flaccidity.
And those distinctions tell a really vivid physiological story. Muscle tone isn't about, how much you lift at the gym.
Right.
It's the continuous passive partial contraction of the muscles, maintained entirely by the nervous system.
So if a limb has flaccidity, it's a complete lack of tone.
Like a rag doll.
And that tells you the nerve connecting directly to that muscle.
The lower motor neuron.
Right. That nerve is dead or severed. The signal isn't reaching the muscle at all.
Exactly. Now, spasticity, on the other hand, is a tightness or stiffness that catches when you try to move the limb quickly.
Like it suddenly locks up.
Yeah. That points to an upper motor neuron issue, meaning the damage is up in the brain or the spinal cord.
Because the muscle is still connected to the local nerve, right?
Yes, but it has lost the coordinating, dampening signals from the brain, so it just fires excessively.
And then there's rigidity, which we'll see later in Parkinson's. That's a constant stiffness throughout the whole range of motion.
Often due to issues in the basal ganglia.
The brain's movement control center. Okay, so that's motor. Then we have the sensory assessment.
Checking, touch, pain, vibration.
And what's wild to me is that these sensations don't all travel up the same wire to the brain.
They really don't. Different nerve fibers carry different types of information, and they literally travel up different physical tracks in the spinal cord.
So if I touch something hot,
the fibers carrying pain and temperature signals, they cross over to the other side of the spinal cord almost immediately.
Right.
And they travel up a pathway called the spinothalamic tract. But the fibers carrying vibration and fine touch, they travel up the same side of the spinal cord in the dorsal columns.
And they only cross over once they reach the brainstem.
Exactly. So think about the diagnostic power of that. If a patient can feel a pinprick on their foot, but they cannot feel the vibration of a tuning fork on their ankle.
That subtle difference tells you exactly which microscopic pathway in the spinal cord is broken.
The body maps out its own damage.
That is incredible. And finally, the third tool, reflexes.
The classic knee tap.
Right. We're looking for hyperreflexia, which are exaggerated, wildly hyperactive reflexes,
Sometimes including clonus.
which is that rhythmic, involuntary muscle contraction. Or, on the flip side, we are checking for decreased or completely absent deep tendon reflexes.
Hecareflexia or ireflexia.
And reflexes act as this pure diagnostic compass because of how the reflex arc works.
Yeah, when a doctor taps your patellar tendon just below your knee, that signal does not go all the way to your brain and back.
It's a localized loop.
Exactly. It travels to your spinal cord, directly synapses onto a motor nerve, and shoots right back to your thigh muscle to cause the kick. The brain is just an observer.
But the brain does send a signal down to chill the reflex out.
Yes, a baseline inhibitory signal.
Yeah.
So you don't go kicking wildly at every minor stimulus.
So if the reflex is wildly exaggerated, hyperreflexia, it means that dampening signal from the brain has been cut off.
Precisely. The localized loop is intact, but the upper motor neuron connection to the brain is damaged.
The brain can no longer inhibit the reflex.
But if the reflexes are completely absent, it means the localized loop itself is broken.
The signal isn't even making it to the spinal cord.
The damage is out in the peripheral nerves. So by combining motor tone, sensory pathways, and reflexes, you can pinpoint the exact location of a lesion before a patient ever goes into an MRI machine.
Biological triangulation. I love that. So armed with our toolkit, let's dive into bucket number 1.
The pure mind attackers.
Right. Disorders primarily affecting mental status, cognition, memory, level of consciousness. And the heavyweight in this bucket is Alzheimer's disease.
Alzheimer's is a degenerative cortical dementia.
And the anatomy here is the key. Cortical refers to the cerebral cortex.
The highly folded outer layer of the brain, where our highest level thinking occurs.
Language, conscious thought, spatial reasoning.
Memory consolidation. In Alzheimer's, you have the buildup of amyloid plaques outside the neurons and neurofibrillary tangles inside the neurons.
Which leads to massive progressive cell death in this specific area.
So the cardinal signs are entirely centered around the erosion of that cortex.
We see progressive loss of cognitive function, deep memory loss, loss of recognition, which is agnosia.
You also see profound personality and behavioral changes, a tendency to wander.
What's devastating is the sequence of this loss. It often starts in the hippocampus, right?
The brain's memory sorting center, which is why short-term memory is typically the first to go.
The brain literally loses the ability to convert a short-term experience into a long-term memory.
And as the cell death spreads through the cortex, it hits the language centers
Causing aphasia.
and the frontal lobes, which alters personality and removes inhibition.
But looking at this through our mind versus body framework, we have to address the physical decline. Because people with advanced Alzheimer's do experience severe physical limitations. They lose the ability to perform activities of daily living. Dressing, bathing, eating.
This is a vital nuance. That physical decline happens because of the cognitive erosion, not because of a primary motor weakness.
The lower motor neurons, the muscles, the physical machinery, the arms and legs, they are all generally intact.
They are fully capable of functioning. They have the physical strength to hold a spoon and feed themselves.
But the mind has forgotten the sequence of steps required to execute that action.
Yes. This is called apraxia, the inability to perform learned, purposeful movements despite having the desire and the physical capacity to do so.
Or, because of the agnosia, the brain simply no longer recognizes what a spoon is.
The body fails because the driver of the vehicle has disappeared, not because the engine is broken.
That distinction changes how you view the progression of the disease. Now, in terms of treatment, they focus on neurotransmitters, specifically acetylcholine.
Which is heavily involved in memory and learning.
Medications like cholinesterase inhibitors are used to block the enzyme that breaks down acetylcholine.
Trying to keep more of that chemical messenger available in the synapses of the dying neurons.
There's also memantine, which regulates glutamate activity to prevent overexcitation of the cells.
But these are management tools. They don't stop the underlying cortical destruction. Alzheimer's is the ultimate slow burn.
It can be quietly developing for a decade before symptoms appear.
But we need to contrast that with the other major entity in our mind attacker bucket.
Right, which represents an acute, immediate shift. We are talking about delirium and increased intracranial pressure, or ICP.
These are grouped together as acute changes in mental capacity.
Unlike the slow cellular death of dementia, an acute shift in someone's level of consciousness, their LOC, is the body sounding a massive, immediate alarm.
It points to the brain being put under sudden metabolic stress or literal physical pressure.
The physics of increased ICP are fascinating. Terrifying, but fascinating. The skull is essentially a rigid, closed box.
It contains exactly three things: brain tissue, blood, and cerebrospinal fluid.
That's the Monroe-Kelly doctrine.
Because the skull cannot expand if the volume of any one of those three components increases.
Say, from a bleeding blood vessel, a growing tumor, or severe brain swelling.
Something else has to give. The pressure inside that closed box rapidly rises.
And the first signs of this rising pressure are changes in the level of consciousness. The patient becomes lethargic, confused, difficult to rouse.
As the pressure mounts, it starts compressing the brain structures and the ventricles, which can trigger projectile vomiting without any prior nausea.
Just sudden, forceful vomiting. But the most alarming manifestation is the Cushing triad.
A late-stage physical manifestation of critically high intracranial pressure.
It consists of three specific vital sign changes: irregular breathing, a widening pulse pressure, meaning the gap between the systolic and diastolic blood pressure gets larger and larger,
And a very slow heart rate. Bradycardia.
Let's unpack the why behind that triad, because it beautifully illustrates the body's desperate attempt to survive.
As the pressure inside the rigid skull increases, it eventually exceeds the pressure of the blood trying to pump into the brain.
The brain is essentially being starved of oxygen.
Right. So to force blood up into this high-pressure environment, the sympathetic nervous system kicks in massively,
Causing the blood vessels and the rest of the body to constrict.
which drives the systolic blood pressure sky high. That's the widening pulse pressure you see.
So the heart is pumping furiously against massive resistance to get blood to the brain. But why does the heart rate drop? Why the bradycardia?
Because as the blood pressure spikes, the baroreceptors in the aortic arch detect this extreme hypertension.
And they trigger a parasympathetic reflex via the vagus nerve to slow the heart down,
Trying to protect the heart itself.
while simultaneously the physical mass of the swelling brain is running out of room.
And it literally begins to be crushed downward through the base of the skull, compressing the brainstem.
And the brainstem controls your basic life support functions.
Exactly. As the brainstem is compressed, the respiratory centers are damaged, leading to the irregular breathing patterns.
So by the time you see the Cushing triad, hypertension, bradycardia, irregular respirations, the brainstem is actively being crushed.
It is a catastrophic neurological emergency.
So in bucket one, we have Alzheimer's eroding the mind over years and increased ICP abruptly crushing the mind's ability to function in hours.
Both attack the mind, but the mechanisms are worlds apart.
Which brings us to a completely different paradigm. Let's transition to bucket number two.
The pure body attackers.
Diseases that cause profound physical decline but leave the mind entirely preserved. The patient is cognitively flawless, fully aware, but trapped inside a failing physical body.
And the most devastating example of this is amyotrophic lateral sclerosis, ALS Lou Gehrig's disease.
A relentless neurodegenerative disorder. The pathology here targets the motor neurons.
Specifically, the deterioration of both the upper motor neurons in the brain and the lower motor neurons in the spinal cord and brainstem.
Because it hits both, you get a combination of symptoms.
From the upper motor neuron death, you get spasticity and hyperreflexia.
And from the lower motor neuron death, you get flaccidity, muscle weakness, and severe atrophy.
Muscle wasting. It manifests as a progressive total body paralysis.
But the defining characteristic, the aspect that makes ALS so unique and so profoundly tragic, is what it does not attack.
Cognition is completely preserved.
The cerebral cortex, the areas responsible for thought, memory, personality, they remain entirely intact.
And the sensory pathways are also spared.
Right. Remember earlier we discussed how sensory and motor nerves run on different physical tracks in the spinal cord.
ALS is incredibly specific. It seeks out and destroys the motor tracks while leaving the sensory tracks alone.
The patient can feel a gentle breeze, they can experience pain, they can hear and see and understand everything happening around them perfectly.
But they progressively lose the ability to move a single muscle in response.
The cardinal signs highlight this progressive asymmetric weakness. It often starts innocuously in one limb.
The patient might find themselves tripping over their own foot due to foot drop, or suddenly struggle to button a shirt.
But it relentlessly spreads. As the disease ascends, it attacks the bulbar muscles,
The muscles controlled by the cranial nerves in the brainstem that govern the face, throat, and swallowing.
which leads to the dystriad. Dyspnea, which is difficulty breathing, dysphagia, difficulty swallowing, posing a massive choking hazard.
And dysphagia, difficulty speaking, eventually leading to a complete loss of verbal communication.
The autonomic nervous system can also be impacted, leading to severe issues like constipation due to lack of mobility.
The grim reality of ALS is the timeline. The disease typically progresses to a terminal phase within 3 to 5 years of onset.
And the ultimate cause of mortality is almost always respiratory failure.
The diaphragm and the intercostal muscles of the chest wall simply become too weak to pull air into the lungs.
Eventually, mechanical ventilation is required to keep the patient alive. Advanced life support. The body succumbs when the mind remains a silent witness to the very end.
Now, if we look at another pure body attacker, we find one with a very different timeline, mechanism, and, thankfully, prognosis.
Guillain-Barré syndrome, or GBS.
The core issue in GBS is an attack on the peripheral nerve myelin.
Myelin is the fatty insulating sheath that wraps around your nerve axons. Think of a nerve like a copper wire, and myelin is the rubber coating around it.
It allows electrical signals to jump rapidly down the nerve. In GBS, the immune system mistakenly targets and destroys this rubber coating.
An autoimmune response, often triggered by a recent viral or bacterial infection.
Classic culprits are a gastrointestinal illness caused by Campylobacter jejuni or a respiratory infection.
The immune system generates antibodies to fight the bacteria, but due to molecular mimicry, those antibodies get confused.
The myelin on the peripheral nerves looks chemically similar to the bacteria, so the immune system attacks the host's own nerves.
And the cardinal sign for GBS is highly specific: ascending symmetric weakness.
It almost always starts distally, down in the toes and feet, with tingling and weakness, and it systematically moves upward through the legs, the torso, and the arms.
The reason it affects the longest nerves first is due to length-dependent vulnerability.
The longer the nerve, the more myelin there is to be attacked, and the higher the chance the electrical signal will degrade before reaching the muscle.
Contrast this with ALS. ALS is often asymmetric and progressive over years. GBS is symmetric, starting at the bottom and moving up rapidly, often over a matter of days.
But just like ALS, it does not affect cognitive function. The mind is perfectly clear.
However, GBS is an absolute medical emergency.
Because that ascending paralysis doesn't stop at the limbs, it can reach the diaphragm and the intercostal muscles, causing rapid, acute respiratory failure.
Plus, the autonomic nervous system runs through these peripheral nerves as well, so patients with GBS can experience terrifying autonomic instability.
Wild swings in blood pressure, dangerous arrhythmias, loss of bowel or bladder control.
When assessing a suspected GBS patient using our toolkit, the reflexes tell the story. GBS is characterized by diminished or completely absent deep tendon reflexes.
Hyperreflexia or areflexia. Because the damage is out in the peripheral nerves, the reflex loop we discussed earlier is broken.
The physical tap on the knee generates a signal, but because the myelin is stripped away, the electrical current leaks out and fades before it can ever reach the spinal cord.
Treating this requires stopping the autoimmune attack.
The primary therapies are intravenous immunoglobulin, or IVA, which floods the body with healthy donor antibodies to neutralize the rogue ones.
Or plasmapheresis, a procedure that physically filters the blood to remove the attacking antibodies.
Because the actual nerve axon is often preserved, if you can stop the demyelination and support the patient's breathing, the peripheral nervous system can actually regenerate that myelin over time.
Most GBS patients eventually recover their mobility. That ability to recover is a crucial difference from ALS.
Absolutely. Now, let's look at a third disease in our pure body bucket, one that gives us a totally different mechanism of weakness: myasthenia gravis, or MG.
In myasthenia gravis, the brain is fine, the spinal cord is fine, the nerve axon is fine, and the myelin is intact.
The problem occurs at the very end of the line, at the neuromuscular junction.
The microscopic gap, the synapse, between the nerve ending and the muscle fiber.
When a nerve wants a muscle to contract, it releases thousands of tiny chemical packets of a neurotransmitter called acetylcholine into that gap.
The acetylcholine drifts across the gap and binds to specific nicotinic receptors on the muscle fiber, triggering the contraction.
In MG, the patient's immune system produces rogue antibodies that specifically target, block, and destroy those acetylcholine receptors on the muscle.
So the nerve is firing perfectly, releasing plenty of acetylcholine, but there is nowhere for that chemical to land. The receptors are barricaded.
The cardinal sign for MG is fluctuating weakness. The best analogy here is a depleting battery. The weakness gets progressively worse with sustained activity and improves with rest.
Let's look at the physics of that depleting battery. When you first wake up, or after a period of rest, the nerve ending is fully stocked with acetylcholine.
The first few times you try to move a muscle, the nerve releases a massive wave of the neurotransmitter.
Even though many receptors are destroyed, there's enough of the chemical flooding the junction to find the few remaining functional receptors and trigger a contraction.
But if you keep using that muscle, if you keep blinking or chewing or walking, the nerve's immediate reserves of acetylcholine get depleted.
With less chemical being released and hardly any receptors available, the signal fails. The muscle becomes profoundly weak.
If you rest, the nerve has time to manufacture more acetylcholine, and the strength temporarily returns.
This fluctuating nature is highly characteristic, and MG doesn't usually hit the large leg muscles first. It preferentially targets the muscles innervated by the cranial nerves.
Specifically the eyes, the face, and the throat. You see ptosis, a drooping of the eyelid.
And diplopia, double vision, because the tiny muscles coordinating eye movement exhaust quickly.
You see significant facial weakness, a loss of facial expression. But the critical danger lies in the throat.
MG causes severe oropharyngeal weakness. This poses a massive aspiration risk.
If the muscles responsible for the complex sequence of swallowing run out of battery mid-meal, the airway is left unprotected.
Food or liquid can easily slip into the lungs, causing aspiration pneumonia.
And in a severe exacerbation, known as a myasthenic crisis, the muscles of respiration can fail entirely, just like in ALS or GVS.
For treatments, you have to find a way to get more acetylcholine to the few remaining receptors.
They use a drug called pyridostigmine. This is an acetylcholinesterase inhibitor.
Normally, an enzyme called acetylcholinesterase sweeps through the junction and cleans up the leftover acetylcholine to reset the synapse.
Pyridostigmine blocks that cleanup enzyme.
It's like plugging the drain in a sink.
By stopping the enzyme, the acetylcholine lingers in the synaptic gap longer, giving it a much better chance of finding a functional receptor.
Because MG is an autoimmune disease, long-term treatment also involves immunosuppressants.
Or even a thymectomy, surgical removal of the thymus gland, which is often hyperactive or tumorous in MG patients, and plays a role in producing those rogue antibodies.
We have one more disorder in this pure physical bucket, and it's highly localized. Bell's palsy.
Bell's palsy is a peripheral nerve palsy specifically affecting cranial nerve the seventh, the facial nerve.
Cranial nerve 7th exits the brainstem and travels through a very narrow bony canal in the temporal bone of the skull before branching out to control the muscles of facial expression.
If that nerve becomes inflamed, often due to a viral infection like herpes simplex, it swells.
And because it's trapped in that rigid bony canal, the swelling compresses the nerve, cutting off its blood supply and its ability to transmit signals.
The cardinal sign is unilateral, one-sided facial weakness. The mental status is totally preserved. It's a pure motor issue of one half of the face.
But the crucial differentiator, the thing that every medical professional must know, is how to tell the difference between Bell's palsy and a stroke.
Because a stroke can also cause a sudden one-sided facial droop.
This is a masterclass in neuroanatomy. Bell's palsy includes the forehead. A stroke typically spares the forehead.
Let's break down the why. It comes down to how the brain wires the face.
The lower half of your face is controlled by the opposite side of your brain. The left hemisphere controls the right lower face, and vice versa.
But the upper half of your face, your forehead and your eyebrows, has dual wiring.
It receives upper motor neuron signals from both the left and the right hemispheres of the brain.
So if you have a stroke in the left hemisphere of your brain, the right lower side of your face will droop because its single power source is gone.
But your right forehead will still be able to wrinkle because it is still receiving backup power from the healthy right hemisphere.
Exactly. The forehead is spared in a central nervous system lesion like a stroke.
But in Bell's palsy, the damage isn't up in the brain. The damage is to the peripheral nerve, cranial nerve the 7th, after all those upper motor neuron signals have merged into a single cable.
When that single cable is pinched in the facial canal, the entire side of the face goes dark.
The patient cannot wrinkle their brow, they cannot smile on that side, and they cannot fully close their eye.
Which leads to a severe risk of corneal abrasion from the eye drying out.
So, if a patient presents with sudden facial droop, you ask them to raise their eyebrows.
If only one eyebrow goes up, the forehead is paralyzed. It's likely Bell's palsy.
If both eyebrows go up symmetrically but the mouth is drooping, you immediately suspect a stroke.
That distinction saves lives, routing stroke patients to immediate acute care while preventing unnecessary invasive interventions for a peripheral nerve palsy.
Okay, we have covered the pure mind attackers and the pure body attackers.
But what about the diseases that refuse to stay in their lane? How do we categorize diseases that don't play by the mind versus body rules and attack multiple systems simultaneously?
That brings us to bucket number 3, the mixed bag.
These are disorders with prominent physical deficits that are also accompanied by cognitive, sensory, language, or perception problems.
The first major player in this mixed bucket is Parkinson's disease.
Now, Parkinson's is fundamentally recognized as a movement disorder, but it absolutely spills over into cognitive and psychiatric domains as it progresses,
The core anatomical issue in Parkinson's lies deep within the brain, in a structure called the basal ganglia, specifically a region known as the substantia nigra.
which produces dopamine. We often think of dopamine as the reward chemical, but in the motor system, dopamine is the essential lubricant for movement.
The basal ganglia works through a delicate balance of go and no-go pathways to initiate smooth, purposeful movement and inhibit unwanted, accidental movement.
When the dopamine-producing neurons in the substantia nigra die off, that balance is destroyed.
The go signal becomes severely blunted, and the no-go signal becomes hyperactive. The entire motor system becomes stiff, slow, and resistant to execution.
The cardinal signs of Parkinson's are grouped into the acronym TRAP: tremor, rigidity, akinesia, and postural instability. Let's look at the tremor first. It is very specifically a resting tremor.
This is fascinating physics. The tremor in Parkinson's typically presents as a pill-rolling motion in the hands when the limb is completely relaxed and supported.
Because the basal ganglia is failing to inhibit background motor noise, the muscles fire rhythmically.
But if you ask the patient to reach out and grab a glass of water, a deliberate, purposeful movement initiated by the cerebral cortex, that strong, intentional signal temporarily overrides the static in the basal ganglia.
And the tremor often lessens or disappears completely. Contrast that with an intention tremor, say from cerebellar damage, which gets worse the closer you get to your target.
The R in TRAP stands for rigidity. We touched on this during our assessment toolkit.
Unlike spasticity, which catches with fast movement, rigidity is a constant gear-like stiffness throughout the entire range of motion, often called cogwheel rigidity.
The A is for akinesia, or more commonly bradykinesia, an extreme slowness of movement.
It takes immense mental effort just to initiate a step or stand up from a chair.
And the P is for postural instability, leading to a stooped posture and a characteristic shuffling gait, because the reflexes that keep us balanced are blunted.
While it starts as a motor disorder, as the alpha-synuclein protein aggregates the pathological hallmark of Parkinson's spread beyond the basal ganglia into the cortex, patients frequently develop cognitive decline.
Depression and eventually Parkinson's disease dementia, it truly becomes a mixed bag.
To treat the motor symptoms, the goal is to replace the dopamine. You can't just give a patient a dopamine pill because dopamine cannot cross the blood-brain barrier.
So pharmacology utilizes levodopa, which is a chemical precursor to dopamine that can cross the barrier, where the brain then converts it into active dopamine.
It's almost always given with carbidopa, a medication that prevents the levodopa from being broken down in the bloodstream before it reaches the brain.
Next up in the mixed bag is an incredibly unpredictable disease, multiple sclerosis, or MS.
The core issue in MS is that it is a demyelinating disease of the central nervous system, the CNS.
We discussed demyelination with Guillain-Barré syndrome, but the distinction here is anatomical. GBS attacks the myelin in the peripheral nervous system, which is created by Schwann cells.
MS is an autoimmune attack on the myelin in the central nervous system, the brain, the spinal cord, and the optic nerves.
This central myelin is created by completely different cells called oligodendrocytes.
And because it attacks the brain and spinal cord, the symptoms are far more diverse and scattered than the ascending paralysis of GBS. The clinical presentation of MS is a scattershot of deficits.
MS leaves behind plaques, or areas of sclerosis, which means scarring, where the myelin has been stripped away.
Because these scars can occur anywhere in the CNS, the symptoms depend entirely on which specific wire was damaged.
If a plaque forms on a motor tract in the spinal cord, you get profound muscle weakness and spasticity.
If it forms on a sensory tract, you get severe numbness, tingling, or neuropathic pain.
If it forms in the cerebellum, you get ataxia, a severe lack of muscle coordination and balance.
And very commonly, if it hits the optic nerve, you get optic neuritis, causing sudden visual changes or temporary blindness in one eye.
Cognition, processing speed, and emotional regulation can also be affected as plaques form in the cerebral cortex.
One of the most fascinating and challenging aspects of MS is its environmental triggers. MS symptoms are famously exacerbated by heat, a phenomenon known as Uthoff's sign.
The physics behind this are remarkable. Heat naturally slows down the conduction of action potentials, the electrical signals, along a nerve.
In a healthy, fully myelinated nerve, that slight slowdown doesn't matter. The signal has plenty of safety margin.
But in a demyelinated nerve, the signal is already incredibly weak and leaking out. A slight increase in body temperature from a hot shower, a summer day, or an intense workout slows the signal just enough that it fails completely.
The patient suddenly experiences a massive flare-up of weakness or blindness, which resolves once they cool back down.
Treating MS involves managing two distinct phases. For an acute relapse, high-dose corticosteroids are used to violently suppress the active inflammation and close the blood-brain barrier.
But for long-term disease modification, patients require complex immunomodulating therapies, monoclonal antibodies or interferons, to try and recalibrate the immune system so it stops attacking the oligodendrocytes in the first place.
Now we come to perhaps the most significant disorder in the mixed bag category because of its sheer prevalence, its acuity, and its profound impact on both mind and body. Stroke.
A stroke is the ultimate sudden-onset mixed bag. The clinical picture varies immensely depending on the exact vascular territory involved.
A stroke is fundamentally a sudden loss of perfusion, a cutoff of blood flow to a part of the brain, leading to rapid cellular death.
There are two main mechanisms, ischemic and hemorrhagic. An ischemic stroke, which accounts for the vast majority, occurs when a vessel occlusion, a blood clot, or a piece of plaque physically blocks an artery.
A hemorrhagic stroke occurs when a weakened blood vessel, often due to chronic hypertension or an aneurysm, bursts, causing arterial blood to bleed directly into the brain parenchyma.
The cardinal sign for any stroke is the sudden, immediate onset of focal neurological deficits. Unlike the slow progression of a tumor or dementia, a stroke happens in seconds.
The brain relies entirely on a continuous supply of oxygen and glucose. It has no metabolic reserves. The moment blood flow stops, the core area of tissue dies within minutes.
But surrounding that core of dead tissue is an area called the ischemic penumbra.
The penumbra is the battleground. It's brain tissue that is hypoperfused, it's starving, it's electrically silent, and it's causing symptoms, but it is not completely dead yet.
It is receiving just enough collateral blood flow to survive for a few hours.
The entire goal of acute stroke management is to restore blood flow to save that penumbra before it joins the core of irreversible cell death.
Let's look at the anatomical differences, because a stroke vividly highlights the localized functions of the brain. The symptoms depend entirely on which hemisphere is hit. Let's start with a left-sided stroke.
For the vast majority of the population, the left hemisphere is the dominant hemisphere for language. If an ischemic stroke hits the left middle cerebral artery, or MCA, which is the most common site, it often devastates two specific areas, Broca's area and Wernicke's area.
Broca's area, located in the frontal lobe, is responsible for the mechanical production of speech. Wernicke's area in the temporal lobe is responsible for the comprehension of language.
If Broca's area is destroyed, you get expressive aphasia. The patient knows exactly what they want to say, their cognition is intact, but they physically cannot coordinate the brain signals to make the words come out. It is immensely frustrating.
If Wernicke's area is destroyed, you get receptive aphasia. The patient can speak fluently, but the words are a word salad, a meaningless jumble, because their ability to comprehend language, including their own, is gone.
In addition to the aphasia, a left-sided stroke causes right-sided hemiplegia or paralysis because the motor fibers cross over in the brainstem.
Now let's contrast that with a right-sided stroke.
The right hemisphere is generally responsible for spatial awareness, proprioception, and emotional regulation. A right hemisphere stroke causes left-sided hemiplegia, but the cognitive and behavioral deficits are entirely different from the left.
You don't usually see aphasia. Instead, you see profound behavioral changes, poor judgment, impulsivity, and a phenomenon that is truly bizarre, hemispatial neglect.
Neglect is a fascinating deficit of perception. The patient's visual pathways might be fine, but the right parietal lobe, which maps out the left side of the world, is damaged.
The brain literally stops acknowledging that the left side of the universe exists.
A patient might only eat food off the right side of their plate, or they might fail to dress the left side of their body, entirely unaware that the left side is there.
The acute management of a stroke is a race against time. For an ischemic stroke, the clot, the gold standard is TPA, tissue plasminogen activator. This is a powerful systemic clot-busting drug.
To get into the biology, TPA works by converting a protein in your blood called plasminogen into its active form, plasmin. Plasmin is an enzyme that physically cleaves and dissolves fibrin, the structural mesh that holds the blood clot together.
If administered within a strict 3 to 4.5 hour time window, it can dissolve the clot and restore flow to the penumbra.
Alternatively, neurosurgeons can perform a mechanical thrombectomy, threading a catheter up into the brain to physically grab and pull the clot out of the artery.
But you must confirm it is an ischemic stroke with a CT scan first. Because if you give TPA to a hemorrhagic stroke, a bleeding vessel, you will dissolve the body's attempts to clot the bleed, massively expanding the hemorrhage and likely killing the patient.
Exactly. For a hemorrhagic stroke, there is no clot to bust. Your priority shifts entirely to managing the secondary damage, the rapidly increasing intracranial pressure caused by the expanding pool of blood. We talked about ICP earlier. To manage this acutely, medical teams use mannitol.
Mannitol is an osmotic diuretic. It's a large sugar molecule that doesn't easily cross the blood-brain barrier.
When you push it into the bloodstream, it creates a massive osmotic gradient, literally pulling water out of the swollen brain tissue and into the blood vessels.
You'd be excreted by the kidneys, thereby shrinking the brain and lowering the pressure inside the skull.
And regardless of the type of stroke, there is one universal, critical physical assessment that must be performed: the swallow screen.
Because strokes frequently damage the cranial nerves governing the throat, the patient is at a massive risk for silent aspiration.
They must receive absolutely nothing by mouth, no water, no oral medications, until a speech-language pathologist or trained clinician confirms they can safely swallow without dumping fluid into their lungs.
Okay, we've navigated the 3 buckets, but we have one final distinct category of pathologies to explore. Sometimes the nervous system isn't slowly degenerating over years, and it isn't suffering from a localized plumbing issue like a stroke.
Sometimes the entire system is actively hijacked by fiery inflammation or chaotic electrical storms. Let's look at the acute intruders.
This brings us to the inflammatory duo, meningitis versus encephalitis. These are both infections that cause severe inflammation inside the head, but understanding their difference comes down to precise anatomical boundaries.
Let's map those boundaries. The brain and spinal cord are not just sitting naked inside the bone. They are wrapped in 3 protective layers of tissue called the meninges.
The pia mater, which clings tightly to the brain surface, the arachnoid mater, a web-like middle layer, and the tough fibrous dura mater right under the skull.
Meningitis is the inflammation of those surrounding layers, the meninges and the cerebrospinal fluid that flows between them. Encephalitis, on the other hand, is the inflammation of the actual brain tissue itself, the parenchyma.
Because the inflammation meningitis is localized to those outer wrappers, the symptoms manifest as meningeal irritation. The classic triad is a sudden high fever, an agonizingly severe headache, and neutral rigidity, which is a profoundly stiff neck.
The meninges also cover the optic nerves, leading to photophobia, a severe sensitivity to light.
The physical examination for meningitis exploits the mechanics of those inflamed wrappers. You look for the Koenig and Brudzinski signs.
If a patient is lying flat and you physically lift and flex their neck forward, you are violently stretching the inflamed meninges down their entire spinal cord.
In a positive Brudzinski sign, the pain is so severe that the patient involuntarily flexes their hips and knees to take the tension off the spinal cord. It's a mechanical reflex to stretching inflamed tissue.
Meningitis can be viral or bacterial. Viral is more common and usually self-limiting, but bacterial meningitis, often caused by Neisseria meningititis or Streptococcus pneumonia, is a fulminant, life-threatening emergency.
The bacteria rapidly multiply in the cerebrospinal fluid, leading to massive swelling, increased ICP, and an altered level of consciousness. The bacteria can also enter the bloodstream, causing a petechial rash and septic shock.
Because of how highly contagious and lethal bacterial meningitis is, immediate isolation with droplet precautions is required for at least 24 hours after initiating aggressive intravenous antibiotics.
Now contrast those mechanical meningeal signs with encephalitis.
In encephalitis, the infection has breached the blood-brain barrier and invaded the cerebral cortex and deeper brain structures. The actual neurons are under attack, therefore the symptoms are fundamentally different.
You still see a fever and a headache, but the primary manifestations are profoundly cognitive and psychiatric.
Because the brain tissue itself is on fire, the patient presents with bizarre behavioral changes, extreme confusion, focal neurological deficits, hallucinations, and frequently seizures.
A very common culprit for sporadic fatal encephalitis is the herpes simplex virus, or HSV, the same virus that causes cold sores.
HSV has a particular affinity for the temporal lobes, which handle memory and emotion, leading to those profound personality changes and hallucinations.
The primary pharmacological weapon against HSV encephalitis is an antiviral drug called acyclovir. Acyclovir works by inhibiting the viral DNA polymerase, stopping the virus from replicating inside the brain cells.
But a crucial piece of biology to remember, acyclovir is metabolized and excreted primarily by the kidneys. If given in high intravenous doses, it can actually crystallize inside the renal tubules, causing acute kidney injury. So, rigorous monitoring of kidney function and adequate hydration are mandatory.
We've covered the inflammatory hijackers. Let's conclude with the ultimate acute disruption of neurobiology, the electrical storms, seizures, and epilepsy.
A seizure is fundamentally an electrical malfunction. It is an abrupt, temporary, altered state of brain function due to a massive, chaotic surge of abnormal electrical discharges from the neurons.
To understand a seizure, we have to look at the microscopic level of the synapse. Normal brain function relies on a perfect, continuous balance between excitatory neurotransmitters, primarily glutamate, acting as the gas pedal, and inhibitory neurotransmitters, primarily GABA, acting as the brakes.
In a seizure, that balance is shattered. A group of hyperexcitable neurons suddenly depolarize simultaneously, firing off a massive, synchronized wave of glutamate overwhelming the GABA brakes. The electrical storm spreads across the cortex.
And just like weather patterns, these electrical storms come in different sizes and follow different tracks. The primary clinical division is between focal seizures and generalized seizures.
A focal seizure, previously known as a partial seizure, originates in one specific localized area of the brain, often a spot where there is a microscopic scar or lesion. Because it is localized, the symptoms map exactly to whatever that specific piece of cortex controls.
Focal seizures are further divided based on whether the patient retains awareness. In a focal aware seizure, the consciousness is not impaired. If the electrical storm hits the motor cortex controlling the hand will uncontrollably jerk.
If it hits the visual cortex, they might see flashing lights. If it hits the temporal lobe, they might experience an aura, a sudden, intense feeling of déjà vu, an inexplicable emotion, or a phantom smell like burning rubber. The patient is awake, watching their own body malfunction.
The second type is a focal impaired awareness seizure. Here, the electrical storm spreads just enough to disrupt the networks maintaining consciousness, but not enough to cause a full body collapse.
The patient appears awake, but their awareness is gone. They might stare blankly, remain entirely motionless, or engage in automatisms, repetitive, purposeless movements like lip smacking, chewing, or picking at their clothes.
A vital clinical detail for focal impaired awareness seizures is that the patient's brain is not recording memories during the event. When the seizure ends, they will have no recollection of what just happened.
Now, if the electrical storm doesn't stay localized, if it erupts and instantaneously involves the entire cerebral cortex in both hemispheres simultaneously, that is a generalized seizure. Because the entire brain is involved, consciousness is immediately lost.
The most dramatic and recognizable is the generalized tonic-clonic seizure. This follows a specific physiological sequence. First is the tonic phase. A sudden, massive wave of excitation causes every muscle in the body to rigidly contract simultaneously.
The patient stiffens, often letting out a cry as air is forced past the vocal cords and they lose posture and fall to the ground. The pupils dilate and breathing stops because the chest wall muscles are locked in spasm.
This rigid phase lasts maybe 10 to 20 seconds, and then the brain's inhibitory GABA pathways try desperately to fight back and stop the storm. This battle between excitation and inhibition causes the clonic phase, violent, rhythmic, alternating muscle contractions and relaxations. The whole body jerks.
There are other variants of generalized seizures. A tonic seizure involves just the rigid stiffening. A clonic seizure involves just the rhythmic jerking. And a tonic seizure is the sudden, terrifying loss of all muscle tone. The drop attack where a patient instantaneously collapses to the ground without warning, carrying a massive risk of head trauma.
A myoclonic seizure involves sudden, brief, shock-like jerks of a specific muscle group. And we must mention the absence seizure, which is primarily seen in children. To an observer, it just looks like the child is briefly daydreaming or zoning out. They simply stop what they're doing and stare blankly for 5 to 10 seconds.
but an EEG would show a massive generalized electrical storm across the entire brain. Now, anyone can have a single seizure. A severe infection, extreme hypoglycemia, or a traumatic brain injury can provoke one. But what separates a provoked seizure from epilepsy?
Epilepsy is the underlying chronic syndrome. The clinical diagnostic criteria specify that epilepsy is diagnosed if a patient has two unprovoked seizures that occur greater than 24 hours apart, or one unprovoked seizure with an MRI or EEG showing a high probability of further seizures.
But there is a scenario where a seizure stops being a self-limiting event and becomes a catastrophic threat to life. That is status epilepticus.
Status epilepticus is defined as continuous unremitting seizure activity lasting for greater than 5 minutes, or two or more sequential seizures without a full recovery of consciousness in between.
The 5-minute threshold is critical. When a brain is actively seizing, its metabolic demand skyrockets. The rapidly firing neurons are burning through oxygen and glucose at an astronomical rate. After 5 minutes, the body can no longer meet that demand.
The neurons begin to starve. Furthermore, the massive flood of excitatory glutamate becomes toxic to the cells, a process called excitotoxicity, causing permanent cellular death.
If status epilepticus is not broken immediately with intravenous benzodiazepines, which massively boost the GABA braking system, the patient will suffer irreversible brain damage or cardiovascular collapse.
When a seizure finally does stop, the brain doesn't just instantly return to normal. The patient enters the postictal state.
The postictal state is a period of profound neurochemical exhaustion. The neurons have fired so intensely that their internal ion gradients are completely depleted. The brain physically needs time to pump sodium and potassium back across the cell membranes to reestablish its resting potential.
During this reboot phase, the patient is transiently confused, profoundly lethargic, difficult to arouse, and they might experience lingering focal weakness.
Because of the chaos and danger of seizures, maintaining physical safety is paramount. If you witness a seizure, you note the exact time it started to watch for that 5-minute status window. You assess the manifestation. Did it start in one hand before generalizing? That tells the neurologist where the lesion might be.
Physically, you protect their head. Once the seizing stops, you place them in a lateral recumbent or side-lying position to keep the airway clear so they don't aspirate saliva or vomit during the sleepy postictal phase.
And the absolute rules of seizure safety. Never forcibly restrain a seizing patient. The muscle contractions are so violent that holding them down can literally snap their bones or tear ligaments. And never force an object, a spoon, a tongue depressor, a wallet into their mouth.
You will only break their teeth, severely lacerate their gums, and create an immediate choking hazard.
So if we pull back from the microscopic synapse and the intricacies of pharmacology, what have we accomplished today? We have traversed an immense landscape, from the slow, quiet erosion of the cortex in Alzheimer's to the explosive systemic failure of status epilepticus.
By categorizing these seemingly disparate disorders into mind, body, or mixed targets, we've revealed a logical, anatomical roadmap. We aren't just looking at lists of symptoms anymore.
If you see a patient whose mind is razor sharp but their peripheral reflexes are completely absent and their legs are rapidly weakening, your brain now immediately routes you to the pure body bucket, specifically the demyelinating pathology of Guillain-Barré.
If a patient presents with sudden right-sided paralysis and an inability to speak, you understand the exact vascular territory in the left hemisphere that is starving for oxygen.
These cardinal signs, the asymmetric weakness, the resting tremors, the fluctuating neuromuscular fatigue, are the body's warning system. They are the physical manifestations of invisible biological failures.
By understanding the underlying physics, the neurotransmitter balances, and the anatomical pathways, you transition from memorizing a textbook to truly comprehending the incredible machinery of human life.
It's all connected.
It has been an absolute privilege to untangle this with you today. Before you go, we want to leave you with one final thought. When we look at how incredibly precise these diseases are, how ALS can systematically dismantle the upper and lower motor tracts while leaving the sensory and cognitive tracts flawlessly untouched, or how Alzheimer's can slowly erase the cortex while leaving the brainstem ticking away, it highlights just how compartmentalized our nervous system is.
But it also raises a profound question about resilience.
Exactly. When these specific pathways are severed, how does the brain's astonishing plasticity attempt to rewire itself around the microscopic roadblocks? Could studying the borders between the tracks that survive and the tracks that fail hold the ultimate key to not just managing these devastating diseases, but coaxing the nervous system to rebuild itself?
It's something fascinating to ponder as you go about your day.